All right, friends, we're back with our next segment of the NYSATA 2022 recap, and we're pleased to bring in Dr. McKeon and Dr. McKeon. Dr. Jen McKeon, who is the Associate Professor and the Athletic Training Program Director at Ithaca College in New York, and then Dr. Patrick McKeon, who is also an Associate Professor, and he's the Athletic Training Clinical Education Coordinator at Ithaca College. And at this presentation, they did a two-part series talking about the head of the talus, and I really appreciate the focus that you two made, because again, this is not just a lateral ankle sprain. This is a little more complex than that, and I love how the two of you broke it down in very easily digestible terms that are super applicable for athletic trainers. So I want to get right into that. First of all, Jen, you did a great job in your presentation breaking down the nuts and bolts of the subtalar joint. You really were clear about this is not just lateral ankle instability. Walk us through that. What's the background on the subtalar joint? What do we need to know before we get into the other stuff?
All right, the background of the subtalar joint, really we have to go back up to the talocrural joint. And so we're thinking about the talocrural joint. We always think about the lateral ligaments, especially with so many of our ankle sprains. But we also know that there's a high recurrence rate for ankle sprain for any individuals suffering from an ankle sprain. And so the lateral ligaments are often implicated, but we don't really look at the subtalar joint, and primarily because it's hard to look at. It's hard to evaluate. It's hard to evaluate manually. It's hard to evaluate on imaging. And so we don't really get at that part of what we would consider the ankle complex. And so the subtalar joint is really going beyond that talocrural joint and going beyond, the CF ligament. We think about the CF ligament as being a primary stabilizer. It is for the subtalar joint, but also there's a series of intrinsic ligaments that connect the talus, the calcaneus, and the navicular. And really that 3-bone complex is the functional subtalar joint. And it's how we get pronation and supination, not just inversion, eversion, but pronation and supination. And so when we have injury to the ligaments that are stabilizing that functional subtalar joint, we can develop a rotary instability. And just like we can have a rotary instability at the knee. And so if we're only looking at the lateral ligaments and really focusing predominantly on the CF when we're seeing lateral ankle sprains, we're missing something. We're missing a piece. Now, that rotary instability is difficult to diagnose because we don't have a lot of great diagnostic tools to get at it. But we can see that if we're assessing more the pronation and supination mechanisms that can happen during the instability, bouts of instability, then we really can start to say this is going again beyond just the talocrural joint.
I love how in your presentation you equated it to the knee, and you said you don't treat an ACL the same way you treat an LCL. It's the same kind of concept, but you don't think of it when it comes to the foot and ankle, because ankle sprains are so common. Everybody just thinks lateral instability. The lateral ligaments are loose. That's what's going on. But the reality is a lot of times there's clinical presentation that we're missing, and that, can we get into that next? What is the clinical presentation of subtalar joint complex instability? And then you mentioned, you alluded to the testing and the stack test that was created. Can you talk to that as well?
Yeah, so much of the clinical presentation for subtalar instability is going to look a lot like what we would just define as classic lateral ankle instability or chronic ankle instability. And one thing I did want to point out is that we can have subtalar stability isolated or concomitant with kind of classic talocrural instability. So it can exist just on its own. But with the clinical exam, really the types of things that we're starting to look for are pain along the subtalar joint line. And so the subtalar joint line is going to go lateral. And so it's going to follow along the sinus tarsi, kind of go around laterally, but it's also going to go around medially as well. So that pain along the medial or lateral borders of that entire subtalar joint line is an important thing. Another thing that is important to look at is pain during walking. And so one thing I didn't mention before is that rotary stability that's necessary for the subtalar joint. That's really where we want people. The subtalar joints with functional subtalar joint has been likened to a transmission, and that the foot has to go from a stacked rigid foot in supination to a more supple flat foot in pronation. And we are constantly in every step going through switching gears, basically from supination to pronation, from a stacked to an unstacked position. And the subtalar joint is key to that stacking, unstacking, that supination to pronation. And so we'd consider that almost a transmission. And so if we're slipping gears during supination to pronation, back to supination while the foot is on the ground, that's going to create pain or bouts of instability while walking, especially on uneven surfaces. And so individuals who are saying, yeah, during walking, even just walking, not putting a lot of pressure through the foot, but just walking, that pronation to supination mechanisms, we're talking about that transmission in time, and then when people might feel pain. Because we're also talking about the medial joint line side and that navicular being involved, oftentimes you'll see a more collapse, not completely flat foot, but a more collapsed medial arch, as the ligaments that are more stabilizing on the medial side at the head of the talus to the navicular may become damaged. So, and then finally, with that joint line pain, really we're starting that joint line pain along the sinus tarsi. So kind of getting into the sinus tarsi gently, but getting into the sinus tarsi and then passing along that posterior joint line are really some of the key characteristics that are associated with the clinical presentation. Now, as far as the testing part, really the two main tests that have been described for subtalar instability: talar tilt, which also tests the talocrural joint, because that's really getting at the CF predominantly, which is crossing two joints. And then also, and so that's our main one. And then a test described, several years ago, roughly 2 decades ago, is the medial subtalar glide test, where you take the calcaneus and then you medially glide it on the talus. That test doesn't have any diagnostic accuracy associated with it. Talar tilt is pretty good for ruling in, so with the positives. But as far as the rotary instability part, Pat and I tried to develop a test that would get at the rotary part of the functional subtalar joint. So we've called that the stack test, where you lock the talocrural joint up into dorsiflexion. So lock that joint right up so it's not moving. Invert the calcaneus to get the inversion, and then adding a more forefoot abduction and external rotation to really get the full supination mechanism. Now, we started out with that, and we also have been thinking that actually bringing the foot back, keeping that dorsiflexion inversion together, but now also bringing the foot into a more flat-footed pronated position, and both looking for any kind of looseness on one side or pain with either of those directions. So we've been kind of playing around with that. The supinated position, the more supinated position, we had some very preliminary, very pilot testy type data, and it seemed to respond positively in a good way, as far as maybe being a good tool, but it really just needs to get more tested. But getting that position of or getting at that rotary component and the pronation supination component of the foot is really what we're trying to get at. That's separate from just only evaluating the talocrural joint or only evaluating the articulation between the talus and the calcaneus.
Yeah, and you alluded to the fact that the subtalar glide and the talar tilt, they're kind of a single plane test, and this rotary instability is really what we're looking for. So it's pretty awesome that you were able to find a way to kind of take up the barriers in that joint and then stress that in a real-time way. So it's exciting that we have another way to differentiate that between just a basic lateral ankle sprain. So fantastic. Well then, Pat, how do we treat this? Once we know what we got going on or have an idea about it, can you talk about some treatment strategies? And then I really love how you framed the overview in your presentation about the return to sport continuum. You referred to PAASS and the different rehab phases that you promote and you teach in your classes.
You got it. Oh, thanks, Ryan. And I think one of the big things about it is through the lens of some of the novel insights derived from the subtalar joint now, or the subtalar joint complex, things I think can become a little bit more clear. And so as Jen was talking about the idea of looking at the subtalar joint, and when we think about the subtalar joint and include the calcaneocuboid joint in there, we can really see a transmission of the foot that shifts us from absorption to propulsion back to absorption when we need it. And even we can extend that out and say that the tibia, the fibula, and the talus really are the shifter of that. So as the tibia rotates internally or externally, that definitely helps to control whether or not we're going into pronation or supination, as well as then stacking or unstacking the foot. When we think about the return to play parts of an ankle sprain, one of the challenges that we face now is that we know 40% of individuals at least are going to go on to have recurrent issues with their ankle. And I think that this is part of the issue, that one of the missing links that we had. And so when we think about return to play decision making, in 2016, there was a consensus statement put out that changed return to sport from a discrete single event into a continuum, which was return to participation, which is really getting into the rehabilitation phase, into returning an individual back to sport, getting them back into their normal demands of sport. And lastly, return to performance, which would be getting them back to their pre-injury levels. And what we know in terms of individuals with ankle instabilities, they have a tendency to go on to become less physically active over time. And so this is a key critical element associated with that maybe we're missing that link of the subtalar transmission in the things that we have. And from a rehab strategy standpoint, I don't think that we need to necessarily change a lot of the strategies that we have, other than the viewpoint that we need to retrain an individual how to use their transmission again. And so part of that, in the early phases of rehabilitation, thinking about addressing ankle restrictions, such as a restriction in dorsiflexion or a restriction in strength, all these components that we know, very, very important, makes sense early on. Shifting towards balance training and single limb stance activities, great. But then moving towards the idea of getting an individual back to a sense of agility, some of the simple rules that we have of keeping the base of support under the center of mass, teaching a person how to move faster without taking larger strides. And so one of the key components we talked about in the presentation were the use of the rockers, and the heel rocker especially. If I take a step far out away from my center of mass, I'm more likely going to use the heel rocker to slow down my forward momentum. And that heel rocker event is a key event that an ankle sprain injury centers around. And we can look at it as a high burden on the transmission, a high burden of absorption on the transmission of the subtalar joint. So getting a person to work more so on agility towards that return to participation, return to sport phase becomes really important. The other thing about that is through that lens, our tendency is to want to also tape and brace the ankle. So if we tape and brace to reduce the motion, but we don't change the movement patterns that are associated with high risk types of high loads on the transmission, we're really working against ourselves. So we know that taping and bracing actually reduce the risk of injury, especially in those with a history of ankle sprain. But maybe one of the component parts is we need to take a little bit more time focusing individuals on agility training with ankle sprains, getting them to be able to get control of the transmission again.
Mm-hmm.
And I love how in your presentation you talked about that progression from strategic to tactical to reactive, as you're going from that just base return to participation to that performance. And that's really much in alignment with what you're talking about, whether it's ankle, post ACL, whatever. You got to teach deceleration and have it be efficient. And you're speaking specifically to the subtalar complex of the deceleration component there and being efficient with it. And when you're referring to rockers, you're talking about where that heel strike lands. If it's out in front of the body, it's more of a shock not as efficient in deceleration in that transmission to the propulsion. So it was really awesome how you framed it that way, which made sense. I'd never heard it referred to as the rocker phases before, but as you spoke through it, I really got it, you know.
I tell you what, the rockers are the most intuitive way to look at gait, in my opinion. It's something that it helps to explain a lot of the aspects of the functional demands of absorption and propulsion when we need them, when we need to transition. But at the same time, I think it provides a really good framework for that missing link of the functional subtalar joint too, as Jen talked about with the stacking and the unstacking, and then the restacking again. You know, one of the things about that with regards to the return to sport phase, when we think about the agility side, that strategic to tactical to reactive type of training really is all about a person's ability to handle uncertainty. So when we think about rehabilitation, especially, we can purposefully ramp up the demands of the task and the environment to really give a person a sense of how much uncertainty can they cope with. And what we know is that if uncertainty ramps up, a person is going to start to freeze. They're going to start to slow down as uncertainty ramps up. So that's going to mean that as changes occur, they're more likely then going to wind up making these high risk moves because they can't keep up with the changes in the situation. So getting a person to be able to cope with uncertainty and thinking through the lens of the transmission of the subtalar joint and how we can follow the rules of agility to help with that all become component parts of good ankle sprain rehabilitation.
And that also is in alignment with something you mentioned, Jen, in your presentation about kinesiophobia and how often people with subtalar joint complex instability, they feel like their ankle is going to give way. I told you my personal story about when I'm walking around with my left ankle. I'm pretty confident this is what I got, and that goes aligned too with if you don't prepare them through their rehab for uncertainty, they're always going to be tentative. They're always going to be hesitant, and then that's going to make it more likely that they get hurt again. So you got to get them to become comfortable with the uncomfortable. So exactly, I really appreciate how you phrased that. Dr. McKeon and Dr. McKeon, thank you so much. Really appreciate your time. Your contact info is in the show notes. And if anyone wants to reach out to you, I'm sure they have many other questions, and I know you'll do a great job of answering them. So thank you so much for your time. Really appreciate it.
Thank you, Ryan.
Ryan. Yeah.
Have a great day.
This is great. Thank you.
You got it.